Okay. Linda, you ready? All right, good morning, and welcome to SNMMI's 2023 Patient Education Day. My name is Mike Crosby, and I'm the Vice Chair of the Society's Patient Advocacy and Advisory Board. We're hosting this event today, and I'm also the founder of Veterans Prostate Cancer Awareness. Our mission is to educate and raise awareness around the #1 diagnosed cancer inside the VA system, prostate cancer, obviously in the name, and help with spreading the word on how to implement these new technologies and new techniques. So welcome to all of you here in Chicago, and also those attending virtually. Thank you all for joining us, and we'll go through a couple of admin notes, but one of the things to remember is we are streaming this session. We'll do the general session this morning and then the breakout sessions this afternoon on YouTube. We're happy to have virtual attendees from across the country and from all over the world. We know that there are attendees from Malaysia, Iraq, Indonesia, and Canada attending this conference and listening in. So we're starting to make a difference. We're spreading our wings and making a footprint around the world and talking about this new technologies and how they can affect your cancer diagnosis and treatments. These are also being recorded, and they will be available on YouTube and also linked to the SNMMI Patient Education Day website. So this is the 12th year that SNMMI and its Patient Advocacy and Awareness or Advisory Board have held this in conjunction with the annual meeting. We currently have 17 different organizations that are part of the Board of Advisors. They all represent different cancers, and they have put in a lot of work and have a lot of great ideas. I'd like everybody that is part of that board to please stand and be recognized quickly, if you don't mind. Yeah, thanks for everything you do all year long. It's a pleasure to see everybody here. Just one housekeeping note: if you drove today and you didn't get your parking ticket validated, please see Karen outside at the desk, and she will make sure that it gets validated. SNMMI is picking up your parking fees for the day. Just want to quickly go over the schedule for today. So in a few minutes, we're going to begin the general session, and it's addressing what is nuclear medicine and molecular imaging and radiation safety. And then there's going to be a presentation about how to understand and evaluate clinical trials, something near and dear to all of our hearts. We'll take that to about 11:30, and then lunch will be served here in the room. We'll also have a guest exciting speaker, Steve Mazan, and Josh Mailman will make the introduction to Steve. He is a patient with neuroendocrine tumors and is the subject of a documentary called Dying to Do Letterman. So it's quite an entertaining luncheon. After lunch, 1 to 1:45, we're going to make a quick swing through the exhibit hall to show you all the background of these wonderful sponsors and their technologies and what they do to provide the new precision imaging and the new technology out there. You're also going to get the chance to see or to be briefed on a poster session, and we'll break into 3 groups. One is neuroendocrine, prostate, and breast, and the researchers will actually go through their poster and tell you why they're doing this research and what it could benefit you and other patients in the future. After the exhibit hall, we'll come back to our breakout rooms. Those will go from 2 to 3:30. You'll see the rooms down the hallway. There's, as I said, neuroendocrine, breast, and prostate. Those are, when that's finished, when those are finished, then we're going to come back to this room where we'll have a fun reception with free food and beverages. And I hope everybody can stick around and do a little bit of networking. We'll try to bring some more people from the hall in here to talk about their technologies as well. So before I introduce our first speaker, I'd like to thank our sponsors who, if they were not sponsoring this, we couldn't get this, this program done. I mean, it's, without their help, it's impossible to do any of this. The industry sponsors this year are Blue Earth Diagnostics, GE Healthcare, ITM, Lantheus Medical Imaging, Novartis, and Telix Pharmaceuticals. So great companies, you'll see them. A little round of applause, please. So a quick reminder that these sessions are being taped and they're on YouTube. Make sure that if you have any questions or that you didn't write them down as they were asked, that they're going to be available to you later on, all right? So let's get started. So our first speaker is Dr. John Sunderland from the University of Iowa. Dr. Sunderland serves as the director of the university's PET Imaging Center and is an associate professor of radiology, radiation oncology, physics, and astronomy. He's also the chair of SNMMI's Research and Discovery Domain and vice chair of the Clinical Trials Network. In his spare time, I'm not sure what else he does, but that's about it. He's going to share an overview of nuclear medicine, molecular imaging, and radiation safety. Please let me welcome Dr. Sunderland.
While I'm setting this up, in my spare time I do CrossFit. Okay, I think I got it. Okay, so three things. First, I'd like to thank the organizers for inviting me. I've done this for the last 3 or 4 years. I really enjoy doing it. Second is my first apology. I'm a physicist by training, and so you're going to be hearing some physics because that's kind of what I do, and that's what actually makes this kind of interesting. And the third is an apology that not too long after this talk, hopefully we'll have time for questions, they have me double and triple booked today, and so I need to run off to my next talk. So if you have questions, try and get them at the end of the talk rather than waiting afterwards. Although I think I'm happy to share my contact information if anybody wants to contact me by email. So what we're talking about today is really what is nuclear medicine and molecular imaging. And so I've divided this into four chunks. The first is just a single slide which tries to differentiate anatomic imaging from nuclear medicine molecular imaging on a very fundamental level. Then we're going to get into what nuclear medicine is and functionally how it works, kind of a nuts and bolts and a physics standpoint because it's important to how it's used. And then we're going to get into some of the diagnostic applications, some of the therapeutic applications. Therapy it's an exploding area of our field right now, and it's really exciting. I'm just going to touch on that. And lastly, we'll get into some radiation safety considerations because we are dealing with radiation, and there's some obvious potential concerns and questions about that. So I'm going to start off here with on the left side of the screen, some examples of anatomic imaging, just kind of standard ones out there that you're probably all familiar with. MRI is in the upper left. MRI is exquisite at imaging soft tissue in the body. It uses magnets and radio frequency waves. There's no ionizing radiation at all. It gives you exquisite, high-resolution images inside the body. You go just to the right, you'll see angiography. This is looking at blood vessels. This is done with X-rays. X-rays is ionizing radiation. They actually kind of blast these through you. This is actually looking at the heart, but more importantly, it's looking at the blood vessels. They inject kind of a dye, a high-density liquid, such that you can actually see in great detail where the blood vessels are and the vasculature is, and you can help look for stenoses and things like that. In the lower left, I love this CT scan. This is highly diagnostic. CT is another X-ray modality but this time they send X-rays through from multiple directions, and they can actually get a cross-sectional image of your body. This is a cross-section of somebody's chest. The heart is in the middle. The kind of black things on the left, and left and right are the lungs. And you can You can see the emphysema down here. You can see the lung nodule up here, which is the lung cancer, and you can see the cigarettes in the shirt pocket up there. Highly diagnostic. Then you have, on the lower right, you have ultrasound that uses sound waves and beautiful real-time in OB and GYN. You can image blood vessels that are near the surface and get great blood flow information. But all of these things are anatomic. We're seeing what's in the body physically, what they look like. That's highly diagnostic and important information. But in nuclear medicine and molecular imaging, we are generally looking more at the function in the biochemistry in the body rather than the anatomy. So what you see on the left, and we'll see this image and others like it, we're in positron emission tomography, we can inject a glucose analog, radioactive glucose analog, and we can look at glucose metabolism, sugar metabolism in the body. You see all that activity up in the brain because your brain is utilizing glucose like crazy. You can see activity in the heart. The heart utilizes glucose. It also utilizes fat for energy. But the kidney is actually a very clever organ. It recognizes this radioactive sugar as an imposter, and so it actually filters it out, which is why you actually see some in the bladder down there. But most importantly, tumors, most tumors, probably 80% of them, are highly metabolically active, and they use glucose like crazy. And so tumors light up like little Christmas tree lights because they're using glucose very rapidly. So this could just be a cyst or something on a CT scan, right? You can see the structure. But this is showing that it's highly active. It shouldn't be there, and this is almost certainly cancer. So we're looking at the biochemistry, the function. On the upper right, we're looking at movement disorders. We're looking at dopamine storage in the brain. It's highly diagnostic for Parkinson's disease. We can inject a different radiopharmaceutical to diagnose Alzheimer's disease. Down in the bottom right, we use it for looking at the function of the heart. What you see kind of over here on the right, so the left ventricle of the heart, it's kind of shaped like a bullet, right? And if you take that bullet and you kind of slice it up and down like that, you'll kind of see it create a C. And so when you see all these colors here, you see there's blood flow getting to all parts of the heart, and that's great. You can also slice it horizontally. That's that bullet shape, and you can see that looks good. You can also look down the barrel of that bullet. All of that looks good. So under resting circumstances, the heart's getting plenty of blood flow. But if you look on the left, under stress, under exercise conditions, you see this area near the apex, the front of the heart, it's not getting nearly enough blood. Right? There's a stenosis that's stopping you to getting enough blood there. If you did a CT scan, the heart's going to look just fine. The muscle is there. Anatomically, it's there. But you don't see what the blood flow is. So what we're looking here at is function. We're looking at biochemistry, and that's kind of the difference between the anatomic images and molecular imaging in PET. So how does it work? So as I've alluded to before, we are injecting radioactive material, but it's not just any radioactive material. We're injecting molecules of, I'll say, physiologic significance. Whatever we want to study, that's what we're labeling radioactively. So this is a sugar molecule. It's almost exactly a sugar molecule except for this green circle down here. Normally there's an oxygen and a hydrogen down here, but our radiochemists have found a way to put fluorine-18 on there. That's a radioactive isotope of fluorine. It decays by positron emission, has a half-life of about 2 hours. So in all cases, when we're doing a nuclear medicine scan, we're introducing radioactivity. Usually it's by injection, but not always. We inject a tiny, tiny mass quantity of radioactivity into the body. So we're injecting, we're not just injecting one molecule here, we're injecting billions. But even if there are billions of these, it still ends up being like on the order of a millionth of a single grain of sugar. A tiny, tiny amount of this drug. But it's enough radioactivity that we can image it and see what the activity is in the body. So we're cognizant of trying to inject as little as possible to get a really good image. It turns out that when these radioactive atoms, that fluorine-18 decays, it gives off gamma rays. It also gives off a positron. We'll talk about that in a minute. It gives off the gamma rays. Gamma rays are just like X-rays, but they come from the nucleus instead of electrons. They function the same thing. They're highly penetrating. They go outside the body, and when you're in a PET scanner or a SPECT scanner, it's the gamma rays that we're detecting. So we always need gamma rays from the radioactive decay. So that's in a nutshell kind of how it works. Here's what happens after you inject in this case, once again, it's the fluorodeoxyglucose into the human body. Normally, you get injected in the arm. In this particular case, I think for demonstration purposes, they actually injected it into a vein in the ankle. And it's kind of going to go through this again. This is almost a second-by-second movie for the first 25 minutes. This is the first time anybody's ever seen what happens to an injection when it goes in. See, it goes in the blood vessel. It's going to make it to the heart. The heart's going to push it through the lungs. Goes back to the heart. It goes through all the other major blood vessels. It starts going to the kidneys and to the liver. You'll see the brain. It's going to start taking up the glucose because the brain's actually using glucose. You'll see that starting getting a little bit darker and darker, representative of the glucose metabolism that's going on there. This patient doesn't have cancer. It's just a normal patient, but that's kind of a normal distribution. For a patient with cancer, just look off to the right. You can see normally we inject. You sit and you rest for about an hour, and then you take a whole body scan, takes about 20 minutes, and you can see the uptake. But most importantly, not just the normal uptake, you can see all of these hot spots that are representative of the metastatic disease that this patient actually has. In many cases, they're easy to read. Sometimes it's a little bit more subtle. So now into a little bit of science, if you'll pardon me for this excursion. You guys probably remember your chemistry in the periodic table, right? I've always considered this a shallow two-dimensional representation of what's actually a three-dimensional space, because each of these elements actually has multiple radioisotopes, right? So we're just going to look at carbon here, okay? So carbon is carbon because it has 6 protons in the nucleus. That's the definition of carbon, right? Most of the carbon in your body is carbon-12. Carbon-12 means the nucleus has 6 protons and 6 neutrons. 6 plus 6 equals 12. And that's a stable nuclear configuration, and that's all great. That's more than 99% of the carbon in your body is that. A fraction of 1% is actually carbon-13, which is another isotope of carbon. 6 protons again, carbon, but it's got 7 neutrons. Okay? That's stable. That's fine. You have some in your body. Carbon-14 has an extra neutron that's shoved in the nucleus that makes the nucleus fundamentally unstable. Nuclei don't like to be unstable. When they're unstable, they're radioactive and they radioactively decay. If they have too many neutrons in the nucleus, they decay by something called beta decay, which means they emit an electron out of the nucleus. And that neutron then turns back into a proton, and it kind of balances out, and everybody's happy again, right? This has a half-life of about 6,000 years. I'm not particularly interested in that. What I am interested in is carbon-11. It has 6 protons, carbon, 5 neutrons, but that's out of balance. It has too many protons for its own good. It has too much positive charge. It wants to get rid of that, and so it ends up happening. It decays by something called positron decay. That's what we use in PET, positron emission tomography. So what happens in that is a proton kind of magically turns into a neutron by emitting an antimatter electron, a positron, out of there. So that's kind of what's going on there. It's quite unstable. It only has a half-life of about 20 minutes. But in our lab at the University of Iowa, we have a cyclotron. We can make carbon-11. And we have radiochemists, and they can take that carbon-11 and they can very rapidly put into a molecule like C11-choline, which is an approved agent for looking at prostate cancer. So we have to do that quickly because it's got a 20-minute half-life, and it's the C11 that's kind of emitting the beacon, the gamma rays, that allows us to locate where it is in the body and to locate where the cancer in fact is. So here's a couple of, there's probably 40 or 50 approved radiopharmaceuticals in PET and nuclear medicine. I'm just going to go through a few and some of the more recent ones. So FES, fluoroestradiol, it's an estrogen kind of type molecule, and that green atom there is an F18, fluorine-18, half-life of about 2 hours. It's used in breast cancer imaging it binds to estrogen receptor positive cancers. Not all breast cancers are estrogen receptor positive. If they are, there are certain treatments that are quite effective, and they don't have many side effects. But you have to know what the receptor expression is, and this can tell you what it is, and it can help your doctor guide your treatment. In the middle is F18 DCF-PYL, PYL for short, or Polarify. This is a prostate cancer imaging agent. It binds very specifically to prostate cancers, to the surface of prostate cancer cells. This is also FDA approved and reimbursed, and it's available all over. It's pretty much revolutionized how we're diagnosing and treating prostate cancer right If you go over to the right, we have copper-64 dotatate. Actually, we have copper-64 dotatate. We have gallium-68 dotatate. Functionally, both the same thing, but two different radionuclides. Gallium-68 is nice because it's got a half-life of about an hour. It's also not nice because it has a half-life of about an hour, and you can't distribute it very far because it decays away. But copper-64 dotatate was approved a few years back. Copper-64 has a half-life of 12 hours. So you can produce it centrally in St. Louis, and you can send it overnight to anywhere in the country. So I'm going to go back to radioactive decay real quick. I'm not going to dwell on it, but I just wanted to mention that we have the negative beta decay, where the neutron's turning into a proton, emitting an electron. That electron travels only about 1 millimeter or so. It never makes it outside of the body. We don't detect it. We don't use it in imaging. Positron decay I'm going to spend a second on because I kind of like it, and it's the reason I kind of got in the field in the first place, because I thought it was cool. In positron decay, you have a proton that turns into a neutron in the nucleus. When it does it, it emits this positron, which is literally a positively charged electron, which is literally an antimatter electron. So yes, there's such a thing as antimatter. This positron travels through the body. It only goes about 1 millimeter or so before it runs into an electron, which is its matter counterpart. You have the matter and antimatter, and just like on the Starship Enterprise and the matter I mean, literally, what happens is when matter meets antimatter, they annihilate. They disappear. They go away. That whole matter can neither be created nor destroyed thing, that's wrong. It goes away. But in its place, you get energy. That's the E equals mc squared thing, right? And the energy is not this amorphous energy. It's two gamma rays that go off in exactly opposite directions. And that's what the PET scanner actually detects. So we're using antimatter and the annihilation of antimatter to actually do our medical diagnosis. And we do this every day, and we do it on 20, 30, 40 patients a day just at the University of Iowa. There's also alpha decay I should bring up. There's a lot of therapy. I'm not going to touch upon it here because these are all in clinical trials right now, but alpha therapy is actually a huge growing area right now. And I just want to mention that in all cases that we're talking about here, when you have any of these kinds of radioactive decays, it's the gamma rays that we're imaging, okay? So we're done with the physics. You can relax. And in all cases, we have the PET scanner that's detecting those 511 keV gamma rays. And if it's we only get one gamma ray photon out, we use SPECT scanners. I'm not going to go too much more into that. What about the process? How do we do nuclear medicine imaging? Typically, we do an injection. Typically, it's in the arm. It's a small volume. We do it over the course of about a 5 or 10 second just kind of push, and we do an infusion. So we do the administration. Typically, we wait a period of time for it to localize. That's not always the case. Sometimes we start imaging right away. Sometimes we wait a shorter period of time. It just depends on the pharmacokinetics of the radiopharmaceutical, right? The scans, depending upon what we're doing, it probably takes 15 or 20 minutes. Some can take longer. Some are actually shorter. And in the end, the images are reconstructed, and within 5 or 10 minutes, the physicians are able to look at them. So it's a fairly simple process. There's a lot that goes on in the background where we're making these radiopharmaceuticals. It gets crazy with the cyclotron production and the radiochemistry. But from a patient standpoint, pretty simple. So just going to go through a couple of the diagnostic applications, kind of current and upcoming, and some of the therapeutics. I'm not going into this extensively, just trying to give you an idea. We talked about the cancer detection that we do with F-18FDG. This is still the bread and butter of positron emission tomography. It used to be about 98% of what we did. Now it's down to probably about 80% of what we do because there's new radiopharmaceuticals that are more specific to different cancers, and so our field is changing. We're doing we can image cardiovascular disease, which I talked about. We can do it with PET, with rubidium-82, and there's another new agent that's going to be coming out probably later this year. We can do it with SPECT and technetium-99 SNMMI. These are all approved. And they're used very routinely all over the country. We also do pulmonary embolism lung imaging. I just put this in because this is one indication where we actually inhale the radiopharmaceutical. It's not injected, so you have a radioactive gas. And you breathe it into your lungs, and you take an image of where the air is actually getting to in the lungs. You combine that with where the blood is going, and you can actually do pretty interesting and important diagnosis on lung function. And then we have movement disorder brain imaging. We also have Alzheimer's disease. I'll talk about that again in a minute. But we're going kind of across the board, across organ systems here. So I'm just going to go through kind of a laundry list of probably 6 or 7 radiopharmaceuticals that are out there pretty quickly. We talked a little bit about gallium-68 DOTA. I have XXX because it could be DOTA-TOC, it could be DOTA-TATE, but they both are somatostatin receptor agents. They're both for neuroendocrine tumors. We can use them for staging of cancer, monitoring of response to therapy, finding recurrence of cancer, finding the primary tumor if they don't know where the primary tumor is. Sometimes you go in, you take out the primary, and that helps a lot. And you can also qualify patients for this radionuclide therapy that I'll talk about in a couple minutes. I'm saying it's not yet ubiquitously available because of that short half-life. It's hard to distribute outside of where you actually make it. But it is approved, both DOTA-TOC and DOTA-TATE, and it's reimbursed. So and this is from, thanks to Josh, this is kind of an old slide, but it does kind of give you an idea of where gallium-68 DOTA-TATE is available, and those circles are about an hour radius, right? So if you're in South Dakota, you're in trouble, or at least you were, because you'd have to travel to where you could get this scan. But since copper-64 DOTA-TATE was approved, now you can distribute it nationally. And so now it's a much more patient-friendly kind of a situation where people can get it in here. So we're working with what Mother Nature gave us, right? And so we're kind of doing the best we can. So this is a copper-64 DOTA-TATE image, and it has all the same information, same binding, same potential uses, et cetera. It's just a different radionuclide. Breast cancer. So here's an example of that fluoroestradiol. And here it's injected. So it's used in the detection of estrogen receptor positive lesions as an adjunct to biopsy in patients with recurrent metastatic breast cancer. So if you get breast cancer, what they usually do is they'll biopsy it to see what kind it is, where the property is, what the treatment might be. But you don't want to biopsy all of the different sites. You don't want to do that. You biopsy one. But that may not be representative of all of them. Right? So if it's estrogen receptor positive, the question, are all of them estrogen receptor positive? And this scan will answer that question and tell you whether you will likely benefit from some of the specific therapies associated with that. It's available pretty much nationally now. It is approved, and it's reimbursed, and it binds to estrogen receptors that appear on certain breast cancer tumors. We talked a little bit about prostate cancer and gallium-68 PSMA. It's exquisitely sensitive for prostate cancer. This is the gallium-68 version that was first approved by UCLA and UCSF, but that's the only place you can get those scans done. But thankfully, not too long after, a company came out with, Lantheus came out with PYL. It's now nationally available. F-18 has a half-life of 2 hours, and it's much more widely distributable. So you can cover really most of the United States with this, and you should have pretty good access around the country. It's approved and also reimbursed, and it binds specifically pretty much to prostate cancers. This is an interesting slide. So really since 2008, we've been able to image amyloid in the brain, right? That's amyloid buildup is what you get in Alzheimer's disease, right? And we said, ooh, baby, we're going to be able to diagnose Alzheimer's disease because nobody could really diagnose it functionally before. But CMS decided they didn't want to reimburse for it because there's no treatment for it. So what if you can diagnose it, there's no treatment? So these have been kind of languishing on the shelves. We've been doing clinical trials with them still for the last 15, 20 years. But now there's one, soon to be 2, Alzheimer's disease treatments available. And they're going to be really expensive. They're going to be $40,000, $50,000 a pop. You want to make sure a patient has Alzheimer's disease before you start doing that. And so for the cost of a scan, because about 20 to 30% of the people they think have Alzheimer's, they don't. So one is anticipating that these amyloid scans are going to become a thing, probably by later this year. And so there's a distribution network already available, and they're primed and ready to do this when and if CMS decides they're actually going to pay for it, and doctors are prescribing it. So this is keep watching this space. This will be really a quite interesting space to watch. I'm going to move into therapy for a second. because this is the direction the field is going. This is, for those of us who are in the field, this is an explosion. This is altering. A lot of the excitement and energy you're going to see out there when you go in the exhibit hall, it's because there's a huge movement in this direction. And so the thing here is, what do we know about radiation? We know radiation in really large doses, we can kill cells. We can kill cancer cells. In fact, external beam radiation therapy for the last 50 years has been doing this, right? And the way you do it, typically, you know, kind of stereotactically, is here's a lung cancer, which is kind of sitting here in the middle. You kind of hit it from one side, and you're actually exposing all of the tissue through here. But then you hit it from another angle, and then there's overlap. So you're getting kind of twice the radiation where the tumor is. And then you hit it from another angle, and you get, and ultimately you get kind of lethal tumor dose to the tumor, and kind of much lower doses to the outside. And so, you know, hopefully everybody kind of lives happily ever after. This is a good way to control cancer. We've been doing it for years and years and years very successfully, and getting way, way better at it. But it kind of makes you think when you look at some of those images that we were looking at. When we're sending radioactivity really specifically to tumors, right? But we're just trying to send a little bit. We want just enough to image. And we're doing it with things with short half-lives, so they disappear quickly. But what if you did it with something that wasn't just a little bit of radioactivity, but what if we injected a lot? And what if it didn't have a half-life of an hour? What if it had a half-life of a week? So this is a patient with gallium-68 at 1 hour half-life, huge tumor burden, right? So what they did with this patient is they injected lutetium-177 dotatate, same molecule, something with a half-life of about a week, and they injected 200, not quite 100 times more, but quite a bit more, okay? So it goes to the tumors, and every time lutetium decays, it emits a beta particle. It emits an electron, and that electron distributes radiation dose. It's like a little bullet. It's a little bullet that's hitting the tumor cells, hitting the tumor cells, hitting the tumor cells. And it's not much anywhere else, so it's kind of sparing most of the rest of your global tissue. So it's being very focal about its radiation treatment. And so this patient with widely metastatic disease after being treated with lutetium-177 kills the vast majority of these cells. Now, this is an extreme case. Patients don't always respond like this by any stretch, but there are a lot of cases like this, and a lot of cases have their disease controlled very well with this particular methodology. And so when this got approved, there was a lot of excitement around here in the field. Neuroendocrine tumors, it's an orphan indication, it's pretty rare, but there are other cancers that we can target as well. So the use of diagnostic nuclear imaging to qualify patients, followed by, that's the gallium study, followed by therapeutic nuclear doses is called theranostics. It's also called targeted radionuclide or targeted radiopharmaceutical therapy. You may hear about it in different things. So this is another case. I'm not going to belabor it, but here we have disease, and then it clears up quite well. This is the clinical trial, the results of the clinical trial. You don't have to read these, but the kind of the light green is the patients that got Lutathera. This is progression-free survival. Patients who got treated with a previous standard of care recurred much quicker, whereas people on the Lutathera side had much more durable response. So it got people thinking about prostate cancer, right? Because we have these things where these agents, gallium-68, F18, PYL, where we can image prostate cancer really clearly, right? So what if we injected a lot of lutetium-177 PSMA instead of the fluorine or gallium? And so here's some cases. There are 6 of them on the left. The red is the disease seen on the pre-scan, and then here's after they gave the lutetium-177 PSMA, here's the post, almost complete response. The numbers down here are the PSA levels, went down to 15 to below 1. Here it went from a PSA of 967 down to 7. Not all of them are complete, and not all of these are durable by any stretch. The prostate cancer comes back, but you can treat a lot of the disease, and you can increase the lifespan and the duration of treatment for many of these. This is the clinical trial for that in patients. And the thing is, we can get way better than this than we are, right? A lot of the scientific work that's being done right now is trying to treat patients very specifically, because some patients can get much more radiation dose than they're getting right now. And we have ways to use imaging to predict how much more you can tolerate without getting toxicity. So we're working a lot in this space. A lot of the science in this space is trying to make these lines diverge quite a bit more than they are right now. Lastly, just real quick, some radiation safety issues. I don't know if any of you have had these scans and all. But when we talk about radiation, I like to use the unit of radiation dose called the millirem. It's 1,000th of a rem, but I like a millirem because that's about how much background radiation we all get in a day. As you're walking around here, by the end of the day, you're gonna get 1 millirem. It's gonna come from cosmic rays that are blasting through the building. It's gonna come from potassium-40 that's sitting in the wall that's naturally occurring. We have some of that in our bodies as well. There's radon gas that's in our home. All of that will give you about 1 millirem. So just kind of remember what that number is, okay? If you get 500,000 millirem all at once, that's probably gonna kill you. So obviously don't wanna do that. You go down by about a factor of 10 to 50,000 millirem, and if people get exposed to 50,000 millirem, we think there may be a small incidence of increase in cancer risk. We don't know that, but the evidence is there that it looks like that's probably the case right now. You go down another factor of 10 to 5,000 millirem, which is what our technologists, the people who do the scans for you in a nuclear medicine center, they can get 5,000 per year. They typically get on the order of about 1,000 per year. There is no really good evidence that radiation workers have a higher incidence of cancer than anybody else. There's some data out there that is suggesting maybe that's the case, but it's really quite unclear. And then if you go down to somewhere between 10 and 1,500, that's how much radiation, millirem, that's about how much radiation you get from diagnostic procedures. Okay, so this is trying to put this all in context. And you get one per day from background. So chest x-rays are pretty low dose. I'm just gonna point out, most of the nuclear medicine procedures are on the order of 300 millirem, which is about background radiation in a year, if you're living in Chicago. Some of them are higher dose, about 1,000 millirem. That's about background radiation in Denver. Background radiation in Denver, by the way, Denver has a lower cancer rate than anybody else, pretty much. And then FDG combination PET and CT scans have between 1,100 and probably 1,800 millirem. You have both the PET scan and the CT scan kind of combined. So that's kind of ballpark. It's still kind of well below what a nuclear medicine technologist can get in a year or what I can get in a year, which is below any kind of demonstrated increased cancer risk. How much radiation is considered too much? It's more than is necessary. We try to tune these tests so we get good diagnostic images with minimal radiation dose. In all cases, and this is the most important thing, in all cases the benefit of the clinical imaging in the opinion of your doctor far outweighs any potential risk. If they're recommending it, then they think you need it. Doesn't mean you shouldn't question it perhaps, but that's what should be going through their mind. Each procedure takes a certain amount of radiation to perform it appropriately. This is well studied. We're coming up with ways to try and do it better. Some of the new scanners are more sensitive, so we can actually do them either quicker or with a little bit less radiation dose. And so we're moving in that direction to the extent we can. Using too much leads to unnecessary radiation dose. We don't want that. But people get too sensitive about this stuff, and they start injecting less activity, and all of a sudden your images suck. And you can miss the cancer you're trying to diagnose. So you have to balance it, kind of on either way. So each imaging procedure is actually optimized for the patient. The SNMMI is involved in 2 dose optimization campaigns, Image Gently for pediatric imaging and Image Wisely for adult imaging. They both promote the use of appropriate procedures for a specific patient. And if you want to have a look at this, you can go to snmmi.org/dose. And I think that'll do it for me. I'd be happy to answer any questions while I can hang around.
Any questions, please? Okay.
Thank you.
Thank you, Dr. Sunderland. Let's give him a hand, please. Okay, great. I'm sure everybody learned something in that slide deck there. I'd like to now introduce our next speaker, Dr. Thor Halfdanderson. I got it. Who's a professor of oncology at Mayo Clinic in Rochester, Minnesota. He's been involved in a number of clinical trials, and including trials researching novel therapeutics. So please join me in welcoming Dr. Halfdanderson. This is yours. Is that you?
Me? Actually, this is an older version. Let's see if I can find the other one. I think we have it on the desktop. So, oh no worries. So, I know I did change that. So, there we go. Oh no, I'm a Mac person, so sorry. I am lost.
Here, you got it?
Oh yeah, this one, the top one here.
The
That's
top
right.
one,
Yep.
okay.
There we
This
go.
one?
Yep, this is it.
All right. Success. There you go.
Fantastic. Well, thank you very much for inviting me to speak here. So I was hoping to spend the next 30 minutes or so talking about clinical trials, and I did actually change the title of my talk because initially it was clinical trials in oncology. So I'm a medical oncologist. So pretty much all I do is cancer and cancer clinical trials. So I have very little experience at running trials in other diseases than cancer. But what I will be discussing is mostly sort of general terms that apply to most clinical trials. So the whole whole objective of this talk is really to try sort of to dispel some of the myths and just inform you of what we sometimes call the clinical trialists are actually doing in the clinic. So I'm mostly a clinician. I'm in clinic every week, every day of the week. So and run a lot of different clinical trials. So here we have the objective. So to discuss the role of the clinical trials, talk about different types of clinical trials, and review some of what's called the endpoint, and then how we all apply this in practice. And then if we have some time at the end, we can talk about how to find clinical trials. So why do we do clinical trials? Well, treatment should be given not because they ought to work, but because they do work. So that is really the whole reason for it. And without testing an intervention, we don't really know if it works. We can make a lot of claims about this or that working, but unless you really rigorously test it, you will not know. So what are clinical trials expected to do? Well, essentially, all of them are trying to do the same thing, is to take a new good idea and apply it to whatever situation there is, and hoping to make a difference for our patients. And I will say not all of these clinical trials or clinical trials for patients. We might be doing clinical trials in otherwise healthy people to try to prevent a disease from happening later. So this is a busy slide with a lot of words, but just some of those are like important concepts here. So the clinical trials, they allow a progressive assessment of clinical interventions. And they may include all or some of the below, so drugs, radiation, imaging, surgery, complementary, alternative medication approaches, and all sorts of things. So clinical trials don't necessarily have to be drugs. And then clinical trial phases, they formalize the types of objectives and assessments, try to maximize the number of patients needed, or minimize the number of patients needed to maximize patient safety and contribution. And then most importantly, trials will provide evidence that can be applied by treating physicians in making clinical decisions later. So I wanted to go through some of the basics and of the trials, and some of this may be, you may be very familiar with this, but all of these trials, they start with an idea. So, so you can have an idea, you were in the clinic, and you saw a patient, and you did this without really having good evidence for that, and it worked. So then you wonder, well, shouldn't it test that in a clinical trial? Or it could be something that's very biologically plausible. It could be something from epidemiology. We've seen that people who live in this area have a higher risk of this particular condition. What if we did this intervention to get them out of that exposure? Would there be a difference? So there's a lot of different ideas that can then lead to hypotheses. But it's, you have to test your hypothesis, and you have to do that either in an observational study or in in experimental studies like trials, and eventually you get some evidence-based information. And without testing your hypothesis, it is just a hypothesis. So, as they sometimes say, the plural of anecdote is not evidence. So although you might disagree with that, so if you have a lot of anecdotes, it is evidence of some sort, but it doesn't, it's not evidence strong enough to make treatment decisions for patients. And what I tell my trainees in the clinic all the time, so we have seen so many beautiful hypotheses slain by ugly facts. So you have something that you think should work in the clinic, but when you put it to the test, well, it may not work. Even worse, it could hurt you. So that's actually one thing that trials are meant to assess as well, is the intervention safe? So clinical trial participation is really disappointingly low. So, and this applies to cancer patients, I'm not as familiar with the non-cancer numbers, but it has been estimated that up to 40% of patients with cancer might qualify for a clinical trial that's open in the country. And yet only about 3 to 4% of patients end up participating in clinical trials. And I even think that's a generous estimate. And there's a lot of different reasons for this. So number one, there might not be a trial available close to you. That's probably one of the main reasons. And or if you were to go on this trial, it would mean a lot of trips back and forth. So there's substantial, what we call financial toxicity. So you have to pay, well, a lot of time on the road, a lot of gas, hotel nights, things like that. Some trials actually do provide some help with logistics. Your provider, your clinician, might not be aware of the trial, or they might just be too busy to think of it, and that happens to me as well. So I might be in the clinic, and then when I'm wrapping up my day, at the end of the day, I think, oh man, that patient I saw at 11 a.m., we actually have a trial, and they didn't mention it. So I pick up the phone and I call the patient and say, by the way, I didn't tell you about the trial we have. And and then the cancer center may just not have the right trial for you. You may have a certain cancer, let's say lung cancer, but they don't really have a trial for that type of lung cancer. And then the inclusion criteria may be too strict, so you think you might, you have the right cancer for this or the right condition, but there is just something else in the criteria that makes you ineligible, and we'll go into that a little bit. And then there is the concern of getting experimental therapy or placebo, and we'll go into that closer to the end. And then obviously the concerns about the risks of new therapy. So you're doing what to me? You're giving me this radiation treatment, and what are my risks, long-term risks? And those are all like very, very valid concerns. And then as we talked about, the multiple trips to the treatment center. So, well, let's go back a little bit and just talk about the definition of a clinical trial. So this is from the WHO. So a clinical trial is any research study that prospectively assigns human participants or groups of humans to one or more health-related interventions to evaluate the effects of health outcomes. And this really applies to all clinical trials, not just cancer. So is all clinical research clinical trials? No. So we can have a lot of other clinical research, and we can broadly classify these into like observational studies and clinical trials. So you have this big sort of a group of clinical trials, and there we have the observational studies, and this would be, for example, I might be following a group of people who live in a certain area, and I might compare them to a group of people living in another area to see if they have different types of cancer or different types of diseases. So these would be sort of population-based epidemiological studies. But then you have the clinical trials who go and follow a completely different set of regulations. So who does clinical trials? So all clinical trials have a principal investigator called a PI, and who may or may not be a medical doctor. And there is usually a global PI for the study. So let's say if there's a study open in the US in multiple different locations, there's a global PI. And then each participating institution has what's called an institutional PI. That's the person responsible for running that trial within that institution. And these trials can be funded by multiple different mechanisms. So there are federal agencies. So for me, it would be the National Cancer Institute for cancer trials, and who work with what's called cooperative groups. I'll show you how that works. There could be pharmaceutical companies, academic medical centers may have some funding to run trials, and then different organizations. And that's just an incomplete list. There's a lot more. So this is how it works for the cancer clinical trials run through the National Cancer Institute. So we have the NCI, National Clinical Trials Network, so that's here, this white circle in the middle, and they collaborate with what's called cooperative groups. So those can be, these are some of the major cooperative groups. And the cooperative groups are essentially groups of hospitals and clinics that actually conduct the clinical trial out in the field. So, and we even sometimes collaborate with the Canadians and some others, and then we have the Community Oncology Research Program. So this is all meant to bring the clinical trial, and in this case for cancer patients, out to as close to the patients as possible. So, and with the oversight of the NCI. So the reasons for doing the trials would be to add, obviously, medical knowledge regarding the treatment, diagnosis, prevention, and more, to evaluate the interventions, discover ways to prevent the disease. These would be the prevention trials, and then also, and I wish we had more of these trials that actually look at quality of life and how to manage symptoms over time. Some of the treatment clinical trials will actually have a component of that, but not all of them do. So clinical trial participation is by far the best way to move the field of medicine forward. So if we don't do trials, there will be very limited advances. So when is it appropriate to participate in a clinical trial? I'd say it's always appropriate to consider a clinical trial. That doesn't mean that you have to sign on. So you always should ask your provider that question. So is there a clinical trial that's suitable for me? And I tell my patients who come to Mayo, they may travel from afar, and they say, do I have to come here to Mayo every month or every 3 months? And I tell them, no, as long as everything is going well, you don't have to do that. But if your provider at home tells you things are not going well, things are changing, it's going in the wrong direction, that's the time to stop and pause and ask your provider, do you have a clinical trial for me? And if you don't, do you know of someone who has a clinical trial? And I tell my patients, that's the time you actually send me a message. That's when you call me and ask if I have a trial for you. So the trial should obviously apply to your situation. It should ask a relevant question. I can design the dumbest trial ever, so I wouldn't want any patients to go on it. So it has to be a reasonable question, not just necessarily scientifically reasonable, but also reasonable for you. And it has to have the risks and benefits clearly explained, and I'll go through that, how we do that. And then it has to be feasible for you. So it has to be logistically possible to do it. So who can participate in a trial? So that goes into the eligibility criteria. So each trial has a different set of criteria, and I'm not sure if you've ever seen these protocols. So each trial has what's called a clinical trial protocol, and these are typically from 100 to 150 pages long. These are massive documents, and so somewhere like sort of about 1/3 down in the protocol, you'll get to what's called the patient eligibility or patient selection. And that is where things get really tricky. Then you have to have all of the facts for that particular patient. You have to look at the protocol and see if the patient in the office who's interested in this trial meets all the criteria. So we have to know, obviously, do we have the right disease and what prior treatment is allowed. Some trials are very strict. You cannot have had this, and that treatment. If you have had that, you're not going on the study. Others are much more open. And then there are very frequent limitations or on like organ function. If your kidney function is not perfect, then you're not going on this study. And I think we're actually I wish there were more trials that would actually be open to more people with limited organ function. Same thing with poor performance status, meaning that if your disease, whatever it is, cancer or something else, has caused a significant disability where you need, let's say, the help of others with activities of daily living, you may not be a candidate for a trial just for that reason. So I think we need more trials that allow impaired organ function and impaired performance status. And I think there is some push to get that done. Okay, so the types of clinical trials, so we have a lot of different types. So I'll go through those fairly quickly here. So we have prevention trials. So can we prevent a certain disease or condition from happening to individuals at risk? And this could be, let's say, just pick something. Let's say someone has high cholesterol. We put them on a cholesterol medication. Half of them go on cholesterol medication. Half of them don't go on cholesterol medication. And then we just count how many did have heart attacks and strokes in the two groups. And is there a difference? Did that preventive medication help or prevent that person from having that outcome of interest? Screening trials, we don't see a lot of, but we see them like in lung cancer. So can we find disease where it's easier to treat, at an early stage when it's easier to treat and treat more effectively? We have diagnostic trials. We saw some examples of that before, so for prostate cancer and breast cancer. And then we have the treatment trials. So the treatment trials have what we call different phases. So, and again, being an oncologist, I have to use the cancer trials as an example. So first you have to find the population, so define that, and the objectives of the study. So phase 1 trials, here we're actually looking at often multiple different tumor types. We're testing the safety of the drug. We're trying to find the ideal or the best dose and try to figure out the tolerability. How high can we push the dose before a person can starts having side effects? Phase 2 trials, and there is some overlap here. So now we're typically one tumor type, and now we're looking at refining the dose. We have an idea about the dose. Now we're trying to find what is really the best dose. And here we might be testing 1 or 2 different doses. And now we're starting to look at activity. And then we go into the phase 3 trials, and here we're looking typically at one tumor type, and we're looking at efficacy and comparison. Try to compare one treatment to another. And then lastly, the phase 4 trials is long-term safety and efficacy. So just to go quickly through some of the different phases here. So phase 1 trials is typically looking at new drugs or new combinations not previously used in humans. So these may be drugs coming right out of the lab. And so trying to find a safe dose, as I talked to you about. In cancer trials, we sometimes are targeting different like mutations or genetic abnormalities. So a person, we can have 10 different tumor types, but we're only interested in this particular mutation. And if you have that mutation, it doesn't matter if you have breast cancer or lung cancer, you might actually be eligible for that particular trial. And here the primary objective is safety and tolerability. And so the critical component here is really careful monitoring and documentation on everything that happens on the study. So the individual benefit is not a target of the phase 1 studies in general, although we do look at some activity, but it's not really the primary objective. So the phase 2 trials are larger, typically less than 100 patients though, and so typically include one tumor type, at least in the case of cancer trials. And here we're trying to establish if there is efficacy, so does the treatment work? We're learning more about the side effects and often trying to sort of figure out what would be the best dose. Some phase 2 trials are randomized, so now we're comparing 2 different studies, but typically not large enough to say with certainty that one treatment is better than the other. Then we have the phase 3 studies. So these are the trials that are randomized by design, so meaning that we have no say in who gets what. So a person has, let's say, a certain cancer, and they meet all eligibility criteria for the study. They get randomized to either the active treatment or what's called the comparison arm. I'll show you a picture of that. And then it can be placebo, and now we're actually comparing 2 different interventions to see if one is better or better tolerated than another. And that may compare a standard therapy with a new therapy option, or may compare standard therapy with the standard therapy plus another drug, or even sometimes occasionally a different dose or a different schedule. But these could even be, we have randomized trials of intervention. We could have a randomized trial of like knee arthroscopy for knee pain versus Tylenol. Or, so I'm just saying that it doesn't have to be like a medical, like a drug intervention. It can be any kind of intervention. So we talk about the arms of the clinical trials, and people say, well, what are these arms you're talking about? And so we have eligible patients. we do randomize them. The computer flips a coin and tells us this patient goes on that treatment, this patient goes on this treatment. And so some go on the experimental treatment, and that would be the experimental arm. Others go on the reference treatment or the standard treatment, and that would be the reference arm. Sometimes the randomization is what's called 2-to-1 randomization. So for each, for 2 patients go on the active treatment, 1 patient goes on the placebo or reference treatment, which doesn't have to be placebo, can be on other treatments. So, and just to show that how this sort of works on if you sort of really step back and look at it, so you have to have the population, that's the patients with this particular disease, let's say this particular cancer. Then you can't test all of them, so you have to have a sample that represents the population you actually want to test. And then you have the intervention, you have the treated group, and you have the control group, and then you look at the outcomes, and then we'll talk about the endpoints here in a little bit. And then you just really statistically carefully compare these 2 different groups and see how they did. So all trials have endpoints. So there has to be something we have to measure. So this is really important for the trials, and different trials look at different endpoints. So cancer trials often have life expectancy as an endpoint, or a response rate, how much can we shrink the tumor, and then there is typically what's called a primary endpoint, which is the main question we're trying to answer, but because we're doing the trial, we can answer all of these other questions too, and that would be the secondary endpoints. Often those would be like tolerability, quality of life, things of that nature. Then we can have exploratory endpoints. Well, now that we have all of these patients on this study, we're testing this particular drug against this other drug, why don't we throw in this additional new blood test to see if that helps telling us who might benefit from this drug over that drug. So we can, and those are called exploratory endpoints. Those are typically very low risk interventions. Look, yeah, if you sign on to this trial, do you mind if we take an extra vial of blood once a month? And we test this exploratory endpoint. So these are all things that you need to know before you go on a trial. So let's talk briefly about the survival, because this is what we hear or what we deal with in cancer a lot. So the median overall survival is probably one of the most commonly reported number in cancer trials. So it's an average number. So when your doctor tells you the median overall survival in this treatment is, let's say, 20 months, that does not mean that you have 20 months to live. It just means that in the group of patients that were tested on that trial, that was the number they came up with. And the definition of a median overall survival is the time from start of therapy until half of the patients have died. Or it doesn't have to be death. It could also be the time from start of therapy until half of the patients needed another therapy, or until half of the patients had side effects or something of that nature. And and similar concepts we have for progression-free survival, that's like the time until the tumor actually grows. Or recurrence-free survival would be, let's say, if you have 100 patients who had surgery for a type of a cancer, and half of them got some therapy afterwards to try to keep the cancer from coming back, then we look at the recurrence-free survival. That's the time it took from the surgery until the cancer showed up again. So try to sort of make like a little picture to show you how this works. So at the beginning of the trial, we have a number of patients. So we are interested in the time point where half of the patients have actually met that endpoint, be it death or cancer coming back or something else. And that time point would be the median overall survival. And like I said, this doesn't apply to individuals. So I hear that a lot of times I may be talking to someone in the clinic, and I may say, well, in this particular study, the median progression-free survival was 14 months, and that means on average 14 months until we needed to do something else. And then I get a message like the following day, and from the daughter of the patient who said, my mom told me that she only has 14 months to live. So, and that some of it is just that we don't have, sometimes it's just hard to explain all of this adequately. It's almost as if you need another extra appointment just to talk about the clinical trials and all of these numbers and stuff. So, and as I said before, the median numbers don't have to necessarily always mean or refer to life expectancy. So the 5-year overall survival, this is a little easier term for people to understand. So it's so this is, let's say we're looking at life expectancy. So you do a treatment, and then you look at how many of the patients are alive 5 years from starting the treatment. And this is something we use very, very commonly after surgery for cancer. So let's say 500 people have surgery for colon cancer, half of them get this particular treatment afterwards, half of them get a different treatment, and we see how many in each group made it out to 5 years. And that's called the 5-year overall survival. So those can be a little bit easier to wrap your mind around. So what about placebo? So this is, and Josh has told me that this is actually one of the concerns, one of the most common concerns that patients have. So is there still a role for placebo-controlled trial? And I'm going to be here defending placebo, but you have to, it doesn't apply to all trials. So we're seeing less placebo-controlled trials in cancer patients, but there is still a role for it. So, and we may need the placebo arm to really know if a treatment is truly effective. Sometimes there are regulatory requirements. So the FDA may require that you do a placebo-controlled trial to grant a drug an approval. So, and that we've seen multiple times, and I think is more common in non-cancer trials. And then it's done to minimize bias and confounding factors. With confounding factors is all the noise that's going on in the clinical trial that may actually blur the results. And then a lot of the trials, placebo trials, actually have what's called a crossover mechanism. So when are placebo-controlled trials appropriate? So one option, well, like one situation would be where there is truly no good treatment left. So so that might be a reasonable thing to have a placebo-controlled trial. Indeed, there was a very prominent colon cancer study just published 2 weeks ago on that in patients who had very few options left. And then trials of interventions to improve symptoms or quality of life. So let's say you have a new drug for neuropathy for whatever reason, and now you might really want a placebo trial there because you have half of the patients who have neuropathy and you have and get no treatment for it, and half of them who have not neuropathy and get treatment for it. And you really need to know, how did the people with neuropathy who didn't get treatment, how did they do? And also keep in mind that some conditions, like neuropathy, gets better over time. So maybe there was no difference. So maybe that particular drug didn't work, or it did work. So there are definitely reasons to do placebo-controlled trials and of those kinds. And then we have to be sure that going on placebo is not going to be deleterious. So let's say you have someone, let's say what I do in clinic is neuroendocrine tumors. So there are patients who can safely go on placebo trials because you know that their tumors are unlikely to grow much in the next 1 or 2 or 3 years even. And I'll show you some examples of that. So this is one example. So this study was published probably almost 10 years ago, called Clarinet, looking at a drug called lanreotide in patients with metastatic neuroendocrine tumors. So all of these patients had advanced cancer. And 204 patients, they were randomized. Half of them got lanreotide, half of them got placebo. And here the primary endpoint was progression-free survival. So the time, average time it took the tumors to grow to a certain extent. And if we look at the curves, these are called survival curves. So what I wanted to show you here, in the placebo arms, the median progression-free survival was 18 months. So at a year and a half from going on placebo, half of them had no tumor growth. So this, I would say, this would be a reasonable trial to have a reasonable population to have a placebo-controlled trial. So, but for someone where the cancer is very fast growing or causing a lot of symptoms, I would not want to put someone who's extremely symptomatic on a placebo-controlled trial, saying, just try to tough it out for 2 or 3 months and let me know how it goes. And so that would not be an appropriate situation for placebo-controlled trial. So let's then go into the crossover design. So patients may say, yeah, I'm willing to consider that placebo-controlled trial, but what if things grow, or what if things are not going well? Will I then be able to get on the active arm? And more trials are now having a crossover design. I'll tell you a story of a a neuroendocrine tumor trial that's been going on in the US for a number of years now. That trial did not have a crossover arm. It was testing a drug against placebo, and then at the time of progression, there was no crossover. And very, very few people wanted to go on it. It had some other issues, and the trial was fixed, and now crossover was allowed, and some other things were, adjustments were made, and now the trial has like 300 patients who are on it. And so this is the way crossover works. So you have patients who meet criteria for the trial. They are comfortable with going on placebo. They get randomized. Half of them will get the intervention, the drug or the procedure or whatever you're giving them. Then when they meet that endpoint, when they progress or whatever, they come off the study and think about the next step. The patients who get placebo, they obviously go on the placebo. They are followed super carefully with scans every so often and monitoring of side effects and the symptoms and whatnot. When there is progression, they can cross over. So now instead of coming off the study, they actually start on the other arm or start all over again. And so this is becoming more and more common now. And I think in many ways this is a really ideal study design. So sort of winding down here, so I just wanted to show you this, what I call the life cycle of a clinical trial. So the way things work with the trials, you have, we talked about all of these things. You have an idea, you start developing the trial, you activate it, you do it, and then you analyze the data, you publish your findings, and then you close the study. And then hopefully you have moved the field forward. So how does this all work in practice? So I think we've seen some of this before. So we have a concept that you want to test. And so the concept can be your own idea. It can be an idea from industry. It can be an idea from NCI. And they just say, hey, I know that you see a lot of these patients. Are you willing to run the trial? And then you do a feasibility assessment. Do I really see enough of these patients to enroll them on the study? Well, if it's not feasible to run for whatever reason, you just don't move forward. You put this through scientific review at your institution, and the people may look at it and say, that's a terrible idea. I would never put anyone on that trial. And then you don't move it forward. So there's a lot of like safety checkpoints along the road. And then you do, finally you do what's called the institutional review board. That's like a final safety check. And if all is good, you activate the study. If it's rejected, which is uncommon if it passed through scientific review, I don't think it's ever happened to me. And then you might have to reject it. So, and how does it work when you decide to go on the study? So now you're in the clinic and you're interested in going on a clinical trial. So I may have ideas. I may say, hey, I have this trial here that we're running. Are you interested? Or sometimes now you may have been flagged by the system. So you walk into the clinic, you check in, and just because of that disease and the treatment you're on, the system may actually flag you. This person is a potential candidate for trial. We're not using much of this, but I think this is I think this is something we have to really consider in the future. Or you may come in and say, hey, I was actually talking to a friend of mine. He was telling me of this trial that you had, and he has the same, we're in the same support group, and tell me about your trial. So it can, and then there can be other mechanisms. So, and you do quick eligibility check, right tumor, kidney function good, liver function good, those kinds of things. That's sort of a very cursory eligibility check. And you think everything is checking out okay. So, well, if you're not eligible, then obviously we're not going to go forward. If and then discuss obviously the trial, the details. Well, this is this is the schedule. You have to be here this and this often, and so on and so forth. And then patients may say, well, no, after hearing that, I'm not interested. So you just stop them. And well, if there is interest after presenting this, you meet with the trials coordinator and often a research nurse, and that's where they get into the weeds of the eligibility criteria. And we do, and if you're not interested when you hear about some more of the details, you might not want to proceed. And then we do the final eligibility check. And if you're not eligible, well, we don't enroll you, and we look at other treatment options. If you meet all eligibility criteria, we can continue and enroll you in the study. So once you're on the study, what happens then? So every trial is a little different, but we follow very detailed protocols. You have to be like at certain times, you have to be at the clinic for certain tests, scans, blood tests, things like that. But you can at any given time come off the study. You may say, well, I'm just not comfortable with being on the study, or I just moved 3 hours away and I just can't do this anymore. Those would be a couple of reasons for coming off study. But once you're on it, you really have to agree to follow this really rigid protocol. Eventually, hopefully, I think we'll be able to move some of this closer to the patient's homes with remote monitoring, so we could do blood work at home, do video visits. If there's one thing that COVID taught us is that we can actually do a lot of things really well virtually. And there are certain things we can't do well virtually, but blood tests, and I can ask a person, and I can sit in Rochester and I can get a really good idea about someone's side effect, someone who lives in North Dakota, and I might actually also see their cat. And so it's, I found virtual visits incredibly personal, much more than I ever thought. So this is just a little cartoon I found from a magazine at the University of Minnesota. Just sort of like snakes and ladders. You start with an idea, and then you may go up a stair, or you may step on a snake and go backwards. So it's just a whole sort of process of passing through a lot of different steps before you can actually get your trial activated and get the results that you really want, and at the end of the day help your patients. So that takes me to the end of my talk. So thanks to Elise Cohn at NCI, who lent me some of her slides, and all of my past and present mentors, all of the research personnel, wherever they are and in whatever capacity they serve. And obviously greatest thanks to the patients who have participated in the clinical trials, or even are just considering trials, families, friends, and their caregivers. So that's it for me. Thank you.
Yeah, thank you, Doctor. Any questions from the crowd? I'm sure there's a couple. Jan?
Hi, Jan Manwright from Cancer ABCs. I wanted to thank you for mentioning that not all clinical trials have placebo. In prostate cancer, for example, most of our clinical trials are compared now clinical trial drug to standard of care. So that's really important for patients to understand. That means they'll get some type of treatment. Also, I tell I call them callers, people who call me for information, to work directly with the clinical trial nurse as closely as possible, because one of the things she's doing is trying to get all your medical records, and we all know that takes longer than it should. So I tell them to just hand the medical records to them and speed up the process. Some patients don't want to wait 3 weeks to get enrolled in a clinical trial. I also tell patients they can drop out whenever they want of a clinical trial. Sorry, I know you don't like to hear that, but it does help them, you know. So they
I tell them the same.
Yeah. And another thought is that sometimes you might get access to a drug for free that we don't know if it's going to make the market. So you may be able to get your cancer, see that drug and be treated by that drug because you were in the clinical trial. For example, I know 2 patients who have been on TAC 700 now for more than 3, 4, 5 years, which never made FDA approval, but is beneficial to them. So those are some thoughts to throw into because it really is just a treatment decision when you're trying to balance out risk and benefit like any other time. So thank you.
Those are all really excellent points. And so as for the dropping off the trial, you certainly always can do that. We did try to study this when I was at the University of Iowa. We tried to look at patients with lung cancer who were on trials versus those who were not on trial, looking at the sort of patient satisfaction. The tool that we had wasn't great, but the patients who were on the trials were actually, they reported sort of like higher overall satisfaction with their care. I think it was because now they're meeting with like trials coordinators and the trials coordinator people are very passionate, and these are very kind people who really want to make a difference. And so I think just you're meeting with more people, you get a little bit more time to talk about your condition, and I think that's valuable.
You get that feeling of a team, which everybody
Yeah.
wants. Thank you.
So, hi, Laura. You didn't bring out your little model from yesterday.
Oh, the
other
mini
Dr.
Thor? No.
Yeah. So a couple questions. I think you brought up that 40% of cancer patients would qualify for a clinical trial. Did you give the number of those that participate?
About 2 to 3%.
2 to 3%.
Yeah.
I've heard a little higher, but not much higher. We've got 40-ish people here. How many of you have actually enrolled in a clinical trial? 2, 3, 4, 5, 6. So 6 out of 40? 7. So we're a little higher than than what would be. So that's great. But yeah, one of the other things. There's 2 other points I wanted to make. Last resort. One of the things you and I have talked about is that a lot of both physicians and patients view clinical trials of last resort. I know you brought up a little bit that you should look at them throughout the journey, your life cycle of working with disease. How does that work, or when should you start looking at these things, or should be a conversation with your treating physician almost immediately?
I think it should be almost immediately. So, for example, at Mayo right now, for a lot of diseases, we have a trial at any given point. We have what we call a first-line trial, a second-line trial, a third-line trial, a basket trial, sort of tag-on trials. For a while, we had a trial of intervention for neuropathy for people who were starting the first chemotherapy. We're hopefully going to have a trial of ketogenic diet, and then obviously a lot of patients are asking about complementary alternative trials. We've thought about doing medical cannabis trials, but it's just very hard to standardize those interventions. So at any time, you could always ask about trials.
One last thing. We obviously are patients, we're the end users, we're the consumers of all this after it gets done. We didn't really talk about consuming the data. You showed the Clarinet data, and which is an interesting, placebo versus an active treatment. One of the challenges I see is that people often compare trials to each other, and in that space we had Clarinet and ProMid, which were both placebo trials, and one had a much longer overall progression-free survival, but yet but even the placebo arm lasted longer. So do you want to comment on how we should consume trial data and the challenges of cross-comparing or looking at some of this?
Yeah. So great question. So for that those particular trials, so we had that Clarinet trial that looked at lanreotide in patients with metastatic neuroendocrine tumors. We had the ProMed study that looked at octreotide, sister drugs, very, very similar. So in one trial, the progression-free survival was like 30 months. In the other one, it was 15 months. So people naturally thought, well, lanreotide is much better than octreotide because people went twice as long. But then if you look at the placebo group in Clarinet went actually twice as long as the placebo group in the other trial. So these were very, very different populations of patients. And when you really look into it, these were not the same patients. So the Clarinet patients had much slower growing disease. So it's very, very hard to compare one trial to another. So and that's actually where you might want to talk to your team about sort of helping you with that. And you might even write down or bring them to the clinic and say, I saw this trial, people did like this well on this trial, but then we have that trial or that drug you're going to put me on. and which has numbers which are much less favorable, why do you think I should go on that study? So there is usually a very good explanation to that. As for getting the information out to the patients who participated in that, there's a very sort of active discussion about how, for the patients who actually went on the trials and contributed to the trial, how can we get the information back to them? And that's something I think we need to figure out. So we have another question.
Mine's more of a comment for someone who signed up for a clinical trial, because you talked about cost. But I want people to know that there are free flights that you can take, medical flights that you can take. One of them's called Angel Flight. I used this when I was in Missouri and went to the University of Minnesota in Minneapolis for my treatment, and I recently moved to Alaska, and they have Angel Flight. And if they have Angel Flight in Alaska, they have Angel Flight in your state. So that's a cost that's not necessarily needs to be in there. The other thing is when I went to the University of Minnesota, work with your nurse practitioners or whoever, but they also had a grant system that paid for 60% of my out-of-pocket medical cost. So that was also, so then it was actually cheaper for me to go to Minnesota than it was for me to go in my own state.
Great comments. And sometimes now, some of the trials actually will pay for logistics, and we have two clinical neuroendocrine tumor trials now, and the trial will pay for flights and hotels and gas. And but then you have to be also careful that you don't want to, so there shouldn't be like enticement to go on a trial. So you have to be very careful with that. But it's logistics are very difficult. And if you just look at the map of the United States, and if you look at if you put a dot wherever there is a clinical trial, and we saw the previous speaker do some of that, not with trials, but with availability of imaging, you see that a lot of the population in the US is very, very underserved, and there is a huge need to get trials out to people, get trials closer to them. And I think, personally, we need to rethink the whole trial structure and really look into remote monitoring.
Hi, my name is Leslie Yerger, and I am a metastatic breast cancer thriver, and I go to the Mayo Clinic, and I'm in at least 2 or 3 studies or clinical trials there. And my question to you is, one of them I think might be more of a study. Sure. So is there a difference between studies and clinical trials? And if so, could you explain the difference?
Great, excellent question. So I didn't really spend much time on that. So if you go to a large institution like Mayo or some others, you may be approached and asked to consider a clinical trial. But you will also possibly get 4 or 5 or more invitations to participate in a study. So that could be a registry study. For example, all pancreatic cancer patients, not just neuroendocrine tumor, but any pancreatic tumor patients at Mayo are asked to participate in a longitudinal study of pancreatic tumors. And this has been going on now for 20 years. It's a massive study. And then, so there's a lot of other studies that are going on. Sometimes they have to do with like quality of life. Sometimes they have to do with patient-reported outcomes. There is now, for neuroendocrine tumors, there's a huge study going on, and Josh knows more about this one called NetPro. We actually are working together on this. So this is a study of patient-reported outcomes. So now if you come to Mayo Clinic with a neuroendocrine tumor, you will get this email, say, well, do you want to participate in this NetPro study? And that's like 4 questionnaires over 2 years. And the first one I've just done, it's massive. But it's asking all sorts of questions about the patient experience with this. So those would be the kinds of studies you might be participating in. Some of them might be biomarker studies. For a while, we had a couple of studies at Mayo where patients with neuroendocrine tumors were asked to give an extra vial of blood because we were just testing a new biomarker that we now have actually, as of last month, put into clinical practice, just thanks to the patients who gave that extra vial of blood.
This is a little behind the scenes type of question, but there's 40% of patients might be eligible for clinical trials. I know one of the challenges in working in clinical trials are your resources or the center's resources in opening new clinical trials. And I'm just curious how that is impacting the number of trials that are getting opened at each center, at each place, and what the challenge is. You know, we see challenges, but we're kind of curious from your vision looking out what your challenges are on opening trials and why don't, all trials get opened everywhere, or what is that, how does that work? So that we understand why our centers might offer one thing while another center offers another. So
No, great question. And so we have finite resources, and running a clinical trial is very expensive. It requires a lot of personnel to do it. So I may be approached by industry. Let's say a pharmaceutical company has a drug they want to test in patients that I see in my clinic. And I may pitch this to the scientific review, or actually what's called the feasibility committee, and they may look at me and say, you only saw 5 patients with this condition in the last year. And knowing that less than half of them will go on the study, you're probably never going to get more than 1 or 2 patients on the study. We just don't think this is feasible to open, and they are right. And we were all affected by the Great Resignation after COVID. So we lost every medical center has lost a lot of nurses, techs, research people. So we were not immune to that. So coming out of COVID, the pandemic, we were actually down by research coordinators fairly significantly. And there was a time where we were actually wanted to open trials, but we were just told we don't have the manpower to do it. That thankfully is much better now, as we've been able to bring on more people. So there's a lot of things, and sometimes it's just that the pharmaceutical company comes in and says, I want to test this drug, and the patient you're seeing, and then they say, we're going to give you this X amount of dollars to do this per patient, and we look at this, this doesn't even come close to covering the cost of our staff. So we may sometimes turn trials down because of the budget is just so inadequate. So there's a lot of different reasons for it. So we have another question.
Yeah, just the last summary. So the difference between a study and a trial is in a trial you're affecting the treatment the patient's getting. In a study you're just collecting information on them. Is that a simple
that would
summary?
be, yeah. So in the trial, what's happening is that there is an intervention. So something is being done, and it doesn't have to be randomized, but something is some intervention is being done.
Okay.
sorry, just having dialogue.
Oh, no, yeah, sure.
You know, tying the front part of our day to the back part, or the front talk to the back part, how and when do you incorporate new imaging modalities? How do you describe to patients what their experience and what that language that's going to come for, and how to read their imaging report? And how do you deal with, often patients are concerned about the amount of imaging they have, and how do you counsel people on that? You heard how John was talking to it, but I'm curious how you do it from your end.
Yeah, so I have actually done very similar to what John just did, except he actually showed the data, and you saw how little radiation there is. So I will tell most of my patients, actually the risk of not knowing what's going on is higher than the small risk of radiation. I'm not minimizing the radiation effect, and I know that people are really concerned about this. So there are certain situations, let's say I'm dealing with someone I know I have to follow for 10, 20 years, let's say like a teenage girl or someone in her 20s, reproductive age, and I'm mindful of the radiation exposure, and I might actually rely almost entirely on MRI. And I'm actually doing a lot more MRIs than I've done before, so no radiation exposure, but then 5 or 10% just can't be in the machine. It's just so claustrophobic. As for the new the new diagnostic modalities, when we get a new test, I do introduce that to the patients and explain to them why I think this might be a smart test to do, and then we talk about things like insurance coverage. And as for PET scans, there are some limits there, so we struggle with getting PETs approved all the time. And then lastly, and hopefully I'm addressing all of your points there, it has to do with the reports that now go out to the patients typically before I see the patient. So Mayo is extremely fast with reporting. So you go in for your CT scan, and you're barely out of the room when the report's up. And then there might be a whole day or even a couple of days before you can actually get into the clinic to see me, and then you're seeing this report. So we have to tell people about that. These are very technical reports, and they are not like really standardized. So you may look at one report that you just from a scan you just had, and it looks really alarming when you compare it to the previous report. And then when you come to the clinic, you may actually see that these are actually essentially the same reports, but just very different wording. So challenges with this, but I think patients should have access to all their information as soon as it becomes available. But it comes with a certain cost. So cost of like anxiety and stress.
Okay. All right, thanks everybody. Thank you for the great questions, and I really encourage you to ask more questions. We'll have the contact data for both of the doctors available, so if you have additional questions you want to ask them afterwards, we'll make sure that you get in touch with them. So doctor, thanks very much.
Thank you.
Appreciate it.